In this lecture, we will discuss cholinergic drugs. Before discussing cholinergic drug, let's have a brief introduction with the nervous system. Nervous system can be divided into central nervous system and peripheral nervous system. Central nervous system include brain and spinal cord. Peripheral nervous system means nerve which enter through or exit from the central nervous system, and it includes autonomic nervous system and somatic nervous system. Somatic nervous system mainly control our voluntary activity and supplies skeletal muscle. Autonomic nervous system mainly control our involuntary activity and supplies viscera. Autonomic nervous system further can be divided into sympathetic system and parasympathetic system. So let's see what are the differences between the autonomic nervous system and somatic nervous system. So somatic nervous system mainly supply our skeletal muscles, and autonomic nervous system supply visceral organs. The distal-most synapse of somatic nervous system lies within the CNS, while autonomic nervous system, it lies outside the CNS. The nerve fiber in somatic nervous system are myelinated, while in autonomic nervous system, the nerve fiber, preganglionic nerve fiber are myelinated and postganglionic nerve fiber are non-myelinated. There are peripheral plexus formation in autonomic nervous system, while no plexus formation in somatic nervous system. The main neurotransmitter in somatic nervous system is acetylcholine, while in autonomic nervous system, it is acetylcholine or noradrenaline. If there is a nerve section in somatic nervous system, there is a paralysis and atrophy, while the activity is maintained or there is no atrophy in autonomic nervous system. Now, come to the difference between sympathetic system and parasympathetic system. The origin of sympathetic nervous system is dorso-lumbar or thoracolumbar. Well, in parasympathetic, it have a craniosacral origin, and the parasympathetic fiber accompanies 3rd, 7th, 9th, and 10th cranial nerve. The distribution of sympathetic nervous system, is wide, while it is limited to head, neck, and trunk in parasympathetic. The ganglia lies away from the organ supply in sympathetic, while the ganglia in parasympathetic system lies close to the organ supplying it. The postganglionic fiber in sympathetic system is long, while in parasympathetic it is short. The pre to post ganglionic fiber ratio in sympathetic system is 1:20 to 1:100. Means per one sympathetic neuron, there may be 20 post-sympathetic fibers are there. While in parasympathetic, the pre to post ganglionic fiber ratio 1:1 or 1:2. The neurotransmitter in sympathetic system is noradrenaline, while in parasympathetic it is acetylcholine. So in this diagram, we can see the different type of fibers. Here, there is a single fiber originating from the CNS and supplying to the effector cell, and this is somatic nerve. Then in first picture, you can see two fibers. One is preganglionic fiber and another is postganglionic fiber. The preganglionic fiber is long, and then it snaps in a ganglia, and postganglionic fiber supply the effector cell. And so it is parasympathetic nerve fiber. Well, in this picture, the preganglionic fiber is small, and the postganglionic fiber is long, supplying the effector cell. And it is acting through a noradrenaline, acting on a alpha and beta receptor. So it probably a sympathetic fiber. Here you see a small preganglionic fiber and a long postganglionic fiber supplying to the effector cell having a muscarinic receptor. So it indicates it have a sympathetic origin. By origin, it is sympathetic, but by nature, it is cholinergic, and it supplies the sweat gland. Then the preganglionic fiber are short here, and they supply the ganglion, and there is a release of neurotransmitter. So it is fiber supplying to the adrenal ganglia, adrenal medulla. The neuron that synthesize, store, and release acetylcholine are called cholinergic neuron. And similarly, the neuron which synthesize, store, and release adrenaline or noradrenaline are called adrenergic neurons. So let's see the synthesis, store, and release of acetylcholine. There is an active uptake of choline from the sodium choline transporters, and choline combined with the acetyl coenzyme in the presence of choline acetyl transferase result in synthesis of acetylcholine. Then there is a shifting of acetylcholine into the vesicle where it is stored along with the ATP. When the wave of depolarization comes, the calcium goes inside and combines with the synaptogramins, and then synaptogramins and gravins causes the fusion of this vesicle, resulting in release of acetylcholine. There are few drugs which can decrease the synthesis or release, like hemicolonium. Hemicolonium block these transporters and prevents the entry of choline. Second, besamicol at this transporter inhibit this, so prevent the inward movement of acetylcholine to a vesicle. So it affects storage of acetylcholine. Then botulinum toxin or tetanus toxin, it prevents the release of acetylcholine. Now, when acetylcholine is released, it acts on the receptors, which are called cholinereceptors. After action, the acetylcholine is destroyed by cholinesterase. Cholinesterase break acetylcholine into acetate and choline is again available for uptake. So cholinesterase can be two types: true cholinesterase and pseudo cholinesterase. True cholinesterase present on cholinergic neurons, ganglion, RBCs, and neuromuscular junction, and it rapidly hydrolyzes acetylcholine. Pseudocholinesterase present in plasma, liver, glial cell, and it is not specific for acetylcholine. It can destroy other esters like succinylcholine, procaine, and mevacurium. Then again come to the receptors. Cholinergic receptors can be divided into two types: muscarinic receptors and nicotinic receptor. Muscarinic receptors are M1, M2, M3, M4, M5, and nicotinic receptors are NM and NN. M1, M2, M3 are more. We know much about these receptors. M4, M5 are present in brain, and there are not much information about these receptors. So we discuss more on M1, M2, and M3 receptors. Then M1 receptor. M1 receptors are present in ganglia, CNS, gastric paracrine cells, and they on stimulation they increases the acid secretion, CNS excitation, increase memory, and increase learning. These are actually G protein coupled type of receptor, G protein type of receptor. All muscarinic receptors are G protein coupled receptors. So G protein, on stimulation of this protein, there is an increase in IP3 and diacylglycerol activity. The agonist at this receptor is acetylcholine and carbapenem, and antagonists are atropine and pyringidine. M2 receptors are present in SO node, AV node, atria, and very less in ventricle. And these are also G protein coupled receptors. On stimulation, it decreases the cyclic AMP, and thus there is a decrease in heart rate and force of contraction. Agonists are acetylcholine and carbachol. Antagonists on this receptor, atropine, methacholine. And 3 receptors are more widespread, and they present mainly on the exocrine glands, smooth muscle, and epithelium. They are G protein coupled receptors. On stimulation, increases the IP3 activity and diacylglycerol, and increases thus resulting in increased secretion, vasodilation, and contraction of the smooth muscle. Agonists are acetylcholine, carbachol, and cevimeline. Antagonists are atropine, daripinazine. Then come to nicotinic receptor. Nicotinic receptor are NM and NM. NM receptors are present in skeletal neuromuscular junction, and these are ligand-gated type ion channels. Both nicotinic receptor ligand-gated ion channels, and stimulation of NM receptor result in contraction of skeletal muscle, while NN receptor stimulation result in transmission of impulse or secretion of noradrenaline and adrenaline from the medulla, adrenal medulla. Agonists at NM receptors are acetylcholine, nicotine, while NN receptors, it is acetylcholine, nicotine. Antagonists at NM receptor, tubocurarine, and at NN receptor, it is trimethoprim. Now, important action mediated by the parasympathetic system or acetylcholine. So basically, it is related with the assimilation of food or conservation of the energy. So what are the effects on eye? On stimulation or parasympathetic effect on lacrimal gland. On stimulation of M3 receptor, there is increase in secretion. On iris, iris muscle, on its action is contraction of the sphincter muscle or constrictor pupillae, which result in meiosis. Contraction of the ciliary muscle results loose suspensory ligament, which causes the lens to convex, which makes the lens more convex, and thus the eye is focused for a near vision, and thus parasympathetic system help in accommodation of eye for a near vision. Constriction of the iris also result in proper drainage of aqueous humor by opening the canal of Schlemm. It causes the wider opening of the canal of Schlemm, widening of the canal of Schlemm. Then effect on cardiovascular system. As we know, in heart, M2 receptors are present, and on SA node, when M2 is stimulated, result in decrease in heart rate. AV node, it result in decrease in conduction, and decrease in atria, there is a decrease in contractile strength, decrease in force of contraction. Very less receptors are present in ventricle. Then upper respiratory tract, in M3 receptors are present in bronchial muscle and bronchial gland. So stimulation will result in bronchoconstriction and increase in tracheobronchial secretions. M3 receptors are present in intestinal smooth muscles, and stimulation of this receptor result in increased tone, amplitude of contractions, and secretory activity of stomach and intestine increase. Genitourinary system, contraction of detrusor muscle. There is a contraction of detrusor muscle resulting in increased voiding pressure and urethral pressure, and thus help in urination. Then we have seen that M3 receptors are present in glands, and stimulation, parasympathetic stimulation result in increased secretion, all type of secretion. So whether it is salivary gland, nasopharyngeal gland, lacrimal gland, sweat gland, all the secretions are increased. Then blood vessels. Blood vessels have no cholinergic innervation, but M3 receptor are present in endothelium. So stimulation of M3 receptor result in release of endothelium dependent relaxin factor or nitric oxide, which activate the guanylyl cyclase and thus increases the cyclic GMP, which causes the vasodilation. In male sex organ, it causes the erection by the stimulation of, again, M3 receptor. And come to the nicotinic receptor. Stimulation of NM receptor present in skeletal muscle or neuromuscular junction result in muscle contraction. Stimulation of NM receptor in adrenal medulla result in increased secretion of noradrenaline and adrenaline. Then come to the introduction with the ANS drugs. Cholinergic drugs and adinergic drugs. Cholinergic drugs are the drugs which act on the receptors normally stimulated by the acetylcholine. And adinergic drugs are the drugs which act on the receptor normally stimulated by the norepinephrine. So today we will discuss cholinergic drugs. Cholinergic drug can be divided as directly acting and indirectly acting. Directly acting means they directly act on receptor, and indirectly means they don't act on receptor directly, but they increases the level of acetylcholine which act on receptor. So directly acting can be choline esters and alkaloid. Choline esters, we have acetylcholine, methacholine, carbachol, methanol. Alkaloids are muscarin, pilocarpine, ergoline. So come to choline ester. First is acetylcholine. Acetylcholine, though not therapeutically useful for us, as it has a very short duration and very rapidly it is destroyed by cholinesterase. So it is not therapeutically used in human, but it has a experimental importance. Then methacholine. Methacholine is less susceptible to the cholinesterase and resistant to pseudocholinesterase. It has a muscarinic action, not having a nicotinic action. Carbachol and methanol are not susceptible to cholinesterase. They are resistant to cholinesterase. Carbachol has a non-specific activity that it acts on both muscarinic and nicotinic receptor, while methanol have a muscarinic action. So methacholine are rarely used now. Methacholine by inhalation is used for diagnosis of bronchial airway hyperreactivity in patients who don't have a clinically apparent asthma. So methacholine is only used for methacholine re-challenge test, methacholine challenge test. Then with methanol, B for methanol and B for bowel and bladder. It is used for post-operative paralyticus ileus, where the motility of the intestine is temporarily paralyzed. So after post-operation. So methanol can be used for paralyticus ileus or gastric atomy. It can be used for post-operative urinary retention, but the condition is, the important condition is, it should not be obstructive type of urinary retention. It is not used in obstructive urinary retention. Then neurogenic bladder, congenital megacolon are the therapeutic indication for Methacholine. Carbachol is used topically in ophthalmology for the treatment of glaucoma and the induction of meiosis during surgery. But remember, only in case where first-line drugs are not working. That means carbachol are again not very popular. Then alkaloids, come to alkaloids, pilocarpine, that is obtained from Pilocarpus microphyllus. It can enhance the salivary secretion and help in swallowing. When applied topically, it produces meiosis and decrease in intraocular pressure. So the main therapeutic use for pilocarpine alone or in combination with the physostigmine used to reduce intraocular tension in acute congestive glaucoma. Alternatively, with mydriatics, it is used to break the adhesion between the lens and iris or iris and cornea. Used to treat xerostomia associated with head and neck radiation and Sjogren's syndrome. Pilocarpine oxycytes are the specially designed drug delivery unit to deliver pilocarpine slowly over a period of 7 days. Then cevimeline is a specific M3 agonist. It has a particular effect on salivary gland. It is used to increase the salivary secretion. Therefore, it is used in xerostomia associated with head and neck radiation and Sjogren's syndrome. Muscarin. Muscarin is an alkaloid that is obtained from poisonous mushroom Amanita muscaria. Amanita muscaria. The acute mushroom poisoning is characterized by diarrhea, dyspnea, abdominal pain, lacrimation, salivations, convulsions, coma. Means all muscarinic type of symptoms. Muscarin has no therapeutic action. Acetylcholine, it is an alkaloid that is obtained from Areca catechu. It has a muscarinic as well as nicotinic action. So has been tried in dementia as an enhancer of cognitive function. But again, it has a no valid or no known therapeutic use in humans. Then come to contraindication. It is contraindicated in bronchial asthma, as we know. Stimulation of M3 receptor result in bronchoconstriction and trachobronchial secretions. So it can precipitate bronchial asthma. And peptic ulcer, as we know, the drug by acting on M3 receptor increases the acid secretion. So it may cause the peptic ulcer. Coronary insufficiency. As we know, these type of drugs can cause vasodilation and decreases the blood pressure. And so if the coronary supply is already compromised, these drugs can further create a problem by decreasing the supply. And last is obstructive GI and urinary retention, because when we give this drug, increase in smooth muscle contractions, mean increase in intestinal motility or increase in pressure inside the intestine or bladder may result in rupture. Then come to the anticholinesterase, which is indirectly acting cholinergic drug. So this drug acts by inhibiting the enzyme cholinesterase, either true cholinesterase or pseudocholinesterase. So by inhibiting this cholinesterase, it increases the level of acetylcholine at various cholinergic sites. So how? Let's see how it works. Acetylcholine, when combined with the cholinesterase, result in formation of choline plus acetylated enzyme. So acetylcholine get break into choline and acetyl part acetylate the enzyme. Immediately, this enzyme react with the water and resulting acetic acid production forms the acetic acid and regenerated enzyme. This regenerated enzyme again breaks the another molecules of acetylcholine, and this process continues on. Now, what our anticholinesterase do? They compete with the acetylcholine, and in place of acetylcholine, anticholinesterase react with the cholinesterase. Now, what happened? The complex which form will react with the water very slowly or not even react with the water. So, our anticholinesterase can be reversible anticholinesterase or irreversible anticholinesterase depending on the time on which regenerative enzymes again available for function. So reversible anticholinesterase and irreversible anticholinesterase. Reversible anticholinesterase include centrally acting caprin, donepezil, rivastigmine, galantamine, and centrally and peripherally acting physostigmine. Only peripherally acting neostigmine, pyridostigmine, adroponium, and insecticides are carbaryl, propaxar, aldeca. Here, rivastigmine, physostigmine, neostigmine, pyridostigmines, carbaryl, propaxar, aldecarb are carbamines. Irreversible anticholinesterase are also known as organophosphorus compound, and they are irreversible. They don't free the enzyme. Once they form the complex, it does not react with the water, and so no enzyme again available for metabolizing the acetylcholine. So the compounds are DFP, diisopropyl fluorophosphate, and icothiopate. Insecticides, parathion, malathion, diazinon, nerve gases, sarin, somen, tabun, centrally acting matripronate and dichlorophos. Matripronate forms dichlorophos, both can cross blood-brain barrier. Come to the reversible anticholinesterase, physostigmine. Physostigmine is a tertiary ammonium compound and highly lipid soluble. It can rapidly be absorbed from oral and parenteral site. Topical instillation in eye produces miosis, spasm of accommodation, and fall in intraocular pressure. See, all type of anticholinesterases causes, their effects are just exaggeration of the effect of acetylcholine, because these anticholinesterase drugs they increases the acetylcholine. So the effect produced by these type of drugs are just the exaggeration of the effect produced by acetylcholine. So topical instillation produce miosis, spasm of accommodation for near vision. It also results in fall in intraocular pressure. So can be used for acute narrow angle glaucoma or acute congestive glaucoma. Treatment of anticholinergic drug intoxication or poisoning. Then neostigmine. Neostigmine is a quaternary ammonium compound. It improves the muscle strength, particularly by having an anticholinesterase activity, and little bit it may stimulate the NM type of receptors also. Since it is a quaternary ammonium compound, it is not very, it doesn't have a very good oral absorption. Administered by subcutaneous route or intramuscular. Pyridostigmine. Pyridostigmine is again a quaternary ammonium compound similar to the neostigmine, but it has a longer duration of action and less potent than neostigmine. Adroponium is also a quaternary ammonium compound. Quicker onset of action, have a very short duration of action. On IV, the effect lasts only for 10 minutes. Adroponium is used therapeutically for it is used for differentiating for diagnosis of myasthenia gravis. As when the hydroconium is given, if there is an improvement in myasthenic symptoms, that means it confirms the myasthenia gravis. It also used for differentiating between the cholinergic crisis or myasthenic crisis. When we give hydroconium in myasthenic crisis, the muscle weakness is improved as there is increase in acetylcholine level. But when you give hydroconium in cholinergic crisis, the muscle weakness increases. So indicating this is a cholinergic crisis. The adverse effects are mainly muscarinic types like salivation, sweating, lacrimation, abdominal cramp, diarrhea, sense of constriction of the chest, fasciculation. It also causes neuromuscular symptoms like fasciculation of muscles, fasciculation particularly around the mouth. Then come to the therapeutic indication. Then first is glaucoma. What is glaucoma? In glaucoma, there is an increase in intraocular pressure, which may be due to increase in aqueous humor formation or decrease in drainage. So our drug, what does our drug do here? When our drug causes the meiosis. We have seen our drugs causes meiosis. So contraction of the iris muscle or meiosis, there is a improved drainage of aqueous humor from the canal of Schlemm, as we have seen already that constriction of the pupil result in widening of the canal of Schlemm. So there is a improved drainage, thus help in decreasing the intraocular pressure. And second is myasthenia gravis. In myasthenia gravis, it is myasthenia gravis is a autoimmune disorder in which antibody are formed for NM receptors. So, if we increases the acetylcholine, the weakness can be overcome or muscle strength can be improved. Neostigmine was previously used, but as it has a shorter duration, pyridostigmine is preferred now. Other measures can be other measures are like corticosteroid, which decreases the production of antibodies, azathioprine, cyclosporine, high dose of cyclophosphamide. They are also immunosuppressant. Thymectomy. If the source of antibody is thymus, thymectomy may have, or plasmapheresis. Then post-operative paralyticus EES or urinary retention. So these drugs help in increasing the muscle contraction and relieve the symptoms. For decurarization, what is decurarization? Like we have seen NM receptor presenting neuromuscular junction. Tubocurarin is a drug which bind with NM receptor and blocks these type of receptor and prevent the depolarization of postsynaptic membrane, thus causes paralysis like symptoms. So if we want to reverse this effect, this is decurarization. So what we are doing here, if we give neostigmine, it causes neostigmine. What neostigmine is a anticholinesterase, so it increases the level of acetylcholine. So acetylcholine now compete with tubocurarin. They bind with the NM receptors, and again there is a regain of muscle contraction. So this is decurarization. For preventing the muscarinic type of symptoms, we can add atropine. Then snake venom poisoning. Some snakes like cobra, crate, the poison have a neurotoxic component. So, neurotoxin component acting like a tuberculin. So, here we use adroponium 10 milligram IV for period of 1 to 2 minutes, over a period of 1 to 2 minutes. And later followed by anticholinesterase new statement to maintain the effect. Now, to prevent the muscarinic adverse effect, we can add atropine sulfate. Then Alzheimer's disease. In the Alzheimer's disease, there is a formation of amyloid plaques, neurofibrillary tangles, as well as there is a loss of cholinergic neuron. Loss of cholinergic neuron contributes for learning and memory deficit. So here, centrally acting drugs are required. Here, the centrally acting drugs are preferred as they have a less peripheral side effects. So for this, rivastigmine, galantamine, donepezil are preferred. Then atropine poisoning or belladonna poisoning. Here, physostigmine is preferred as it can reverse both central nervous system symptoms and peripheral nervous system symptoms, peripheral symptoms. Then come to irreversible anticholinesterase. That is organophosphorus compound like parathion, malathion. They are irreversible inhibitor of cholinesterase. High lipid solubility can be absorbed from all routes. They can cross blood-brain barrier and produce CNS symptoms. They have a high toxicity. They are mainly used for as insecticide and have only a toxicological importance. Organophosphorus compound poisoning can be occupational. Most of the time it is occupational, sometimes accidental, and sometimes societal. The symptoms are like meiosis, spasm of accommodation, conjunctival hyperemia, vomiting, abdominal cramps, diarrhea, bronchospasm, pulmonary edema. Nicotinic effect like fasciculation, twitching, generalized weakness, and paralysis of muscle. It can cause confusion, hypotension, respiratory depression, convulsion, coma. Death is usually due to respiratory failure. So management of organophosphorus poisoning. How will we manage organophosphorus poisoning? Is management based on supportive measures and specific treatment. So supportive measures, first we have to terminate the exposure by removing the patient from contaminated atmosphere. We have seen the organophosphorus compound are highly lipid soluble, so they can be absorbed from anywhere, either from the cloth or if it is present in the skin, it can be absorbed from there. So first important thing is to remove the patient from the contaminated atmosphere. Thorough washing of contaminated skin or mucous membrane with water and gastric lavage. Then maintain the airway. ABC, we have to follow the ABC. Airway should be patent. If there is excessive secretion, it has to remove. Then artificial respiration and oxygen. If patient is not able to breathing, then artificial respiration should be provided. Then if there is a convulsion, diazepam should be used and treatment of the shock should be done. Then specific treatment consists of atropine that reverses the peripheral muscarinic symptom. It reverses the peripheral muscarinic symptoms as well as CNS muscarinic symptoms. But remember, only muscarinic symptoms. To do 4 milligram repeated every 10 minutes till the sign of full atropinization occur. Full atropinization means pupil fully dilated and oral mucosa should be dry. Here there is increase in heart rate also. Then, since it reverses only muscarinic type of symptoms, it doesn't reverse neuromuscular blockage. NM symptoms are not reversed. So pralidoxim is added, which is actually a cholinesterase activator, and it reverses NM blockage also. So 1 to 2 grams or 250 milligram of ovidoxin given slow IV. So in this diagram, we see like this is an organophosphorus compound which combines with the cholinesterase, result in phosphorylated esterase formation. When you give auxin, it removes the esterase and bind with the this organophosphorus compound, and our cholinesterase is free. So this is reactivation of cholinesterase. But this pralidoxim should be given before there is a aging. Means before our pralidoxim should be given within 1 to 2 hours or before 12 hours, before the aging occurs. What is aging? Aging means loss of alkyl or alloxy group. When this one alkyl group is lost, the monoalkyl or alloxy group, monoalloxy or alkyl phosphorated compound is formed, which is stable, and our auxin are not able to replace the cholinesterase or not able to activate the cholinesterase enzyme. Now, pralidoxins include pralidoxin, ovidoxin, diacetyl monoauxins. DAM. Ovidoxin is less potent as compared to pralidoxin, but can cross blood-brain barrier. So they are effective in reversing the neuromuscular paralysis. Effective only when administered in a short time period, that is before aging. Auxins are not effective in antagonizing the toxicity of reversible anticholinesterase. We have to remember that it is not effective in reversing the reversible anticholinesterase. It is only effective for irreversible anticholinesterase. Rather, they themselves have a weak anticholinesterase activity. That is, auxins have a weak anticholinesterase activity. So contraindicated in toxicity of reversible anticholinesterase. So thank you for patient listening. Thank you.